at our first legacy event associated with ESGO Congress. As you all know, ESGO is the largest gynecological oncology society in Europe with a strong global reach. However, advancing the science within the professional science is not enough if we want to achieve better outcomes for our patients, because access to care, to prevention, to research is not only associated with scientific guidelines, it is also associated with policy, with public, with awareness, and with healthcare organization. That's why we realized that the close collaboration also with patient advocates, with policymakers, and with general public is crucial if we want to move forward. We were very happy to be approached by wonderful Copenhagen to make this legacy project based on a very simple and powerful message, and it is we would like to create a lasting collaboration and impact beyond the event in partnership with local stakeholders. And we realized that the Congress is a very good platform that can join not only professionals from the field, but also patient advocates and local policymakers. Our legacy program is divided in two streams. In the first part, we would like to show you what Denmark can live on ESGO. And we will show you the successful story of centralization of care in Denmark and how it is associated with improved outcomes for the patients. And we will show you how it is in line with ESGO activities at EU level, where we are currently calling for a strong action to develop EU-wide network of centers of excellency. In the second part, we would like to see what ESGO can improve or help to improve in Denmark, and not only in Denmark. And we would like to focus on how to ensure better and timely access to new treatment modalities, especially drugs, also in the context of new policy making in the global area that influences not only Denmark but also the whole Europe. Because what we would like is that we could imagine a world where your address no longer determines your access to prevention, to care, and to chances of survival. And that's why we prepared this, and we started with partnership between all of us to move things forward. So to start with the first part, I would really like to warmly invite Kim Hulscher as a co-chair for ENGAGE. So ENGAGE is the Patient Advocacy Group Association that works under the umbrella of ESGO. And because the patient voice is actually the most important, because everything what we are actually doing, we are doing something to benefit our female population. We will start with Kim, so she will explain us how the centralization of care and access to care is important from patient perspective.
Thank you so much, Maja. Thank you for having me, and thank you for allowing the patient voice to also be heard here in this event. So I am Kim Hulscher. I'm a cervical cancer survivor from the Netherlands. I work for Stichting Olijf, which is the Dutch cancer patient organization, and I'm co-chair from ENGAGE, which Maja already mentioned. I am a single mom, and my kids were 9 and 11 when I got diagnosed cervical cancer, stage 3C in 2013. When a doctor told me I had cancer, I was completely in shock. She referred me right away to a university hospital in a different city. And the hardest thing at that time was to tell my children I had cancer. And I remember my daughter asking me, "Mom, can you promise me that you're going to stay alive?" And of course I couldn't, because I had no idea at the time what was going to happen. But that was also my biggest fear, right? To stay alive for my children. Because at that time they were still depending on me. And now at 21, 24, they're actually still depending on me. During my surgery, they found out the cancer had spread to my lymph nodes. And so they only removed my lymph nodes. And I had to have chemoradiation and brachytherapy. Brachytherapy is internal radiation. This meant that I had to go to the hospital 5 weeks for 5 weeks, and every day I would get radiation, once a week chemo, and at the end, the brachytherapy. And this is, of course, very tough, very scary, and it's really hard to go through this treatment and take care of 2 children at the same time. However, I am well educated. I have a lot of people supporting me, and I live in the Netherlands. Centralized care is really, really great. It's essential for quality of care. But what if you don't have the money to travel? I could travel to the university hospital in the other city. That was no problem for me. But there are women who do not have the money, don't have a support system, or don't have a car. Also at my job, they were very supportive. It was no problem for me to go to the hospital for an exam. But this might not be the case for other jobs. During my radiation, I got a lot of help. Sometimes my father would bring me, some of my colleagues would bring me, but I could also take a taxi, which would be covered by the insurance. I talked with members from ESGO from Albania. They told me that not all cancer treatments are covered by the insurance. They sometimes have long waiting lists for brachytherapy, and there's not enough capacity for radiation therapy, which is actually very crucial if you're in the highest stage of cervical cancer. Cervical cancer can also cause an extreme amount of late effects, something I had no clue about. This could be bladder, bowel problems, sexual health problems, concentration loss, lymphedema, or infertility. These late effects have a big, big impact on your life and your work, also for me. But you know, I'm a manager, so if I have bowel problems in the morning, I can go in late. I can work online, or I can start later and do something in the evening. That's not possible for every job. When you're a teacher, when you're working in a store, you cannot do that. And I know a lot of cervical cancer patients who lost their job because of the late effects. You know, and since we're talking about gynae cancers here, let's not forget the important role that women play in society, like in education, like in healthcare, as mothers, caregivers, and as role models. So we need to do better and provide for all these women, and not just the ones that are well off, like me. 5 years after my treatment, I got diagnosed with lymphedema. It's so important with lymphedema to get an early diagnosis, because then it can get treated better. When I started showing signs of the lymphedema, I went to the hospital. And it was kind of funny. I think one person looked at the top of my leg, the other one at the bottom. They did not talk to each other, did not look at my file, and they were like separate from each other. There's no problem, just go home, there's no problem. And I just started laughing because I knew it was lymphedema. And I had an appointment, fortunately, with my gynecologist the next week. And she, of course, agreed that it was lymphedema, and I got the right care and the compression. If I would not have known this was lymphedema, it would have taken a much longer time. We hear so often that it takes up to a year for women to get diagnosed with lymphedema. In the Netherlands, treatment and compression is covered by the insurance. But for example, in Greece, we hear that compression needs to be paid by themselves, which is actually very expensive. Also, lymphedema can have a big impact on your work. When you have a standing job, I'm standing here right now, I'm okay for 10 minutes, but then I need to put my leg up. So it's a problem when you're, for example, a teacher or do a different type of job. I did a quick survey among engaged members on support for treatment for late effects. From the Nordic countries, I heard positive answers. Also in the Netherlands, we have expertise centers that are especially for gynae cancers when you have late effects. They're specialized in that, which is really, really great. But in the majority of countries present, there was nothing, and the only support that would be there for late effects was for patient advocacy groups. Also, this needs to be improved. Treatments are getting better. Patients live longer, which is great, but we need to live longer with better quality of life. And let me close with this. Equal access to centralized care, to treatment and to clinical trials is crucial for every woman in Europe. Because without the social challenges and the differences between the European countries and even within communities, a cancer diagnosis itself, just hearing the word cancer, is already challenging and devastating enough. Thank you.
Thank you very much, Kim, for this inspiring talk, so that we really know what we are doing here all together, professionals and policymakers. We are trying to improve the world for all women and for women with cancer. Now I would like to invite the distinguished professor Klaus Høgdall from Rikshospitalet. He is, among other activities, he is also a chair of Danish Gynaecological Cancer Database that is more than 20 years old, and he is the one who will show us the results of the centralization of care in Denmark. Thank you.
Thank you very much for the invitation, and I have been looking very much forward to present our data, which I find is very impressive. At first, Denmark is a little country with only about 6 million inhabitants, and of course the number of ovarian cancer cases are not as great as it is in many other countries, but we have about 550 ovarian cancer cases per year, and it's actually, I can tell you that it's very precise because we have the Danish Gynaecological Cancer Database, which covers about 97% of all cases. So about 550 cases per year. And if we look at the Danish cancer history, we'll see that up to 2002, we had the highest incidence and mortality of ovarian cancer in comparison with nearly all other countries in the world. It was really bad. And in a nationwide survey, we found out that ovarian cancer primary surgery was carried out in about 52 gynecologic departments. That was almost all gynecologic departments in Denmark, and also many surgical departments. So every surgeon could operate ovarian cancer here in Denmark. How was the survival? Here you can see how bad it was compared to our neighbors here in Scandinavia. We had the highest mortality, the worst survival in Scandinavia. And it was even worse here because we had very many patients, which you can see from Denmark, actually had a very good prognosis here because they were not real ovarian cancers. So it was terrifying at that time. Something had to be done. And I will come with a little case story. I was a very young senior resident at a very large regional hospital, and I was booked up for surgery alone on a very young lady with a very large tummy. It looked more like I was going to do a cesarean section and not a laparotomy. And when I opened and started, I found that her omentum was closely adherent to the abdominal wall. And I actually had just come back from 3 years work in a laboratory, so my surgical training was a little rusty at that time. I called the senior, he came, looked down and said, just take a biopsy. We closed again, didn't do anything more, and we didn't find out if it was possible. Could we have done any cytoreductive surgery? But we never found out. We just closed, and maybe it was the best for the patient. Maybe we could have, but at that time we didn't know. We didn't had any knowledge about neoadjuvant chemotherapy. Actually, I don't think you had anything to offer the patient really in oncology at that time, but it was very nihilistic at that time. And that was the problem here in Denmark. You gave up. When you saw an ovarian cancer, the youngest one was set up for operation, nearly the youngest one. So it was, and of course, the treatment was following that nihilistic way to treat the patients. What happened after that? In 2000, the Danish National Cancer Plan was launched to improve the cancer care in Denmark, and with a particular focus on accelerating diagnostic workup and treatment. And it was then recommended that the treatment of ovarian cancer should be centralized to 5 gynecological oncological centers. And actually, after a few years, already in 2003, the number had started to decline, and we were only 3 centers who were allowed to treat ovarian cancer. And we also started to train our gynecologists, the surgeons, in extensive surgery, and training and certification were introduced in the centers. Furthermore, in 2000, the Danish Gynaecological Cancer Group was established, and 2003, the first guideline was introduced here in Denmark, national guideline, and in 2003, we established the Danish Gynaecological Cancer Database, where we had yearly reports with clinical quality indicators to follow our quality. We also introduced the RMI, the Risk Malignancy Index, which is based on ultrasound and the tumor marker CA125. If the calculation based on those markers were more than 200, the patient had to be enrolled in the National Ovarian Cancer Pathway with referral to one of the centers in 3 working days. And there we had a specialist assessment with PET-CT scan and a MDT, multidisciplinary team meeting, to define treatment strategy. And the diagnostic workup and primary surgery had to be completed within 16 working days. But have these actions actually increased the survival? That's, of course, a big question. If we look again at the survival, now you can see that something has happened. We are now in the last, at the end of this, we are the second best compared to Norway. If you see, it's going up and down. So we are quite good now compared with our Scandinavian neighbors. So something has happened. What about other countries? If we compare us with the 7 high-income countries, we can see that we, in this study, we were the second best study with out of 7 comparable high-income countries. So something has happened positively. What about the centralization? If you look at this figure, you will see that we are having a significant better survival for patients who have been centralized compared to non-centralized centers. That was already published in 2010, and we had statisticians looking at it. It was really a lot of statistical work to ensure that it was an independent, better survival based on the centralization. But what has happened since then? Of course, we are still also in the centers trying to improve. And if you look at it here, you can see that we have even improved the survival from 2000 and up to 2022. You can see a very large improvement for late stages 3C and 4 patients here in Denmark. So something has happened positively. The conclusion is that patients treated in central referral centers have a better, highly significant survival, and treatment, and as I told you, it is an independent prognostic survival. The centralization is independent, and the patients, of course, will benefit from treatment in a tertiary referral center. As I told you, we can't do any validation to see if the centralization actually works, because everyone has been centralized since we've published the study. But I think what the last line I showed from the survival up to 22 shows that we have had a positive result from the centralization. But of course, the impact of the other national initiatives will also give us, contribute to this improved survival, but we don't have any robust data to show what has for the single. What about, for example, the RMI and all the other national initiatives we can't say anything about. But we can only conclude that the increase in survival during the most recent period, I think, strongly support the conclusion that the Danish overall strategy has improved the patient's survival. Thank you.
Good morning, everyone. So thanks for this nice meeting. And just to set the scene where we are as ESGO and how we are in compliance with what you are doing and how we want to move forward from what you are doing here in this country and spread it in Europe. So actually, ESGO is doing accreditation for the management of different cancers, as you can see here, in different countries in Europe. So for ovarian, endometrial, cervical cancer, and also for training. And where we want to go, as Maja said, we would like to recognize women's health centers of excellence, and we can go together through this journey. So we start from here, we start from ESGO guidelines, and you see that through the ESGO guidelines, we want to assess what we should do in order to correctly manage cancer in our patients. And then from the ESGO guidelines, actually, we go to the quality indicators. So how we can apply these guidelines to real-life practice, how well we are delivering care in our centers through the quality indicators. So it's like measurement on what we want to propose with the guidelines. And then we go to accreditation. So once we go in a hospital, we are looking for how this hospital is able to implement and practice this kind of quality indicators to ensure equity of quality of care to our patients. And also we want to collect data from these centers, as you do actually in your country, to research purposes or even for policy purposes, you know, to try to change what's not going so well. So let's start from the guidelines. Maybe many of you know what is the guideline process in ESGO. It's a very strict procedure which starts with evidence-based medicine. So we have a methodologist who is taking care of searching in the literature what is evidence-based and what should be proposed for the best of our patients. And then all this information are discussed within a panel several times in order to reach a consensus. But it's not enough because we want to have these guidelines accepted worldwide. So we need feedback from many reviewers all over the world. So they are sent out for external review. This time we had more than 300 people reviewing our guidelines. This ensures that these guidelines are really global and acceptable worldwide. And once we have these reviews, actually, we try to implement as much as possible the reviews within the guidelines, and then we reach the final consensus. So the process is quite long, quite complex, but this ensures the quality and the acceptability of the guidelines. And this is just an example how large is the world of guidelines for ESGO. So actually in February 2026, so right now, we have 24 guidelines topics. And another strength of our guidelines that it's not only ESGO guidelines, we try to share the guidelines with many European and non-European societies for the same purpose. On one side, having it as multidisciplinary as possible and to reach, again, consensus among the different societies. And now let's go to the quality indicators. As I said, from the guidelines, we start, but we reach the quality indicator. So we start from the evidence-based guidelines, and then we select some key recommendations, which we try to translate into measurable indicators to bring back to the community. And so we have three different types of quality indicators: outcome, indicators, process indicators, and structural indicators. So just to make you an example and make it easy to understand, for example, for outcome indicators, we may have the rate of postoperative complications, for example, or the outcome of survival, as you showed. For the process indicators, we are thinking about, for example, operative reports. So in the operative report, we need to, and you will see in the guidelines actually, we need to specify the residual tumor, for example, or the extension of disease, or where the residual tumor is. And for example, also for process, we indicate morbidity and mortality meetings. And the structural indicators means all the facilities that you may have in your hospital, like the access to genetic testing, for example, or the ICU, and so on. So at the end of the story, this is again an example for quality indicators, and these are the bases on which the hospital are then accredited for the management of the disease. And finally, the accreditations. So actually, we have this kind of accreditations. What is important here is, on one side, the wide range of accreditations that we have, which is based on both on management of the disease, but also on training. The second one is that it's a long history, more than 10 years, and we are trying to cover all these diseases, that we have digitalized the process. So actually now everything is on REDCap, and it makes it very easy, and also it makes the access of the data much easier. Again, this is how it works. You have to complete the REDCap information, the REDCap data, and then there is an online self-assessment and also the evaluation from a jury. Just to show you how it works, this is an example on how many accredited centers we have for the management of ovarian cancer and endometrial cancer. And I just made for you an analysis for Denmark. So we have now 2 centers in Denmark accredited for the management of ovarian cancer, actually surgery for ovarian cancer, and we are waiting for you for the management of endometrial cancer. So you are very welcome to send your data. And maybe you may wonder what is the difference with training. And there is a little difference, because we are accrediting centers for training means that it's not only about management, it's about training. So you need to provide a full curriculum for your fellows, and to provide a multidisciplinary evaluation for different diseases, not only for one of them. So it's a little bit different, although not too much. So you have to add the local training program and annual report, and then there is a visit from the jury in the hospital itself. And again, this is a summary on what we have, and a summary for you for Denmark, because we have 3 centers accredited for training in Denmark. Why this is important? This is important because at least one fellow to receive the certification as a ESGO fellow, which means fellow in the European Society of Gynaecological Oncology, needs to spend at least 1 year in an accredited center for training. So having these centers means that you can have fellows accredited by our society. Now, where we want to go, what's going to change? This is the history. We are here since 20 years, maybe 10 years. We are doing this kind of activity, but we want to escalate it on a different level, which is the European level. As you can see, trying to establish this network of Center of Excellence for Women's Health. And the reason is that we want to cover the gap. The gap is fragmentation, and we have 2 types of fragmentation. One is about the health of patients, and the other one is about ESGO itself. So we have fragmented the health of the woman in different diseases, ovarian, endometrial, cervical, and maybe different history. We can have also menopause after cancer or infertility after cancer. Now we want to collect everything together, so have a real holistic approach to the woman health in the whole history of the patient. And of course, there is a fragmentation in Europe regarding different settings, which is not only the management of the disease, but also prevention, follow-up, and survivorship. So we want to cover all the aspects of the women's history. And we all know, and we have already discussed it, what it means, fragmentation. It means delayed in diagnosis, more access to surgery, emergency care, higher costs, and so on. And we are also very much aware that there are other projects in Europe covering the same aspects, but again, mainly covering cervical, comprehensive cancer centers or other initiatives like Chain 2 and so on. So we want to complement what already exists. We are not in competition. We want to provide our experience, and actually we have a lot of experience in terms of accreditation. So this is how we are bringing the voice of ESGO within Europe and how we want to collaborate, covering this gap in fragmentation. Just to make it very brief, this is the last experience that we had. We had an event at the European Parliament at least one month ago, together with Jalid and with Maja, where we called the action Closing the Gap on Women's Health, and where we are going to propose this kind of new network for centers of excellence for women's health. So happy if you join and we work together. Thanks a lot for your attention.
So I would warmly like you to share with us your thoughts, questions, ideas. I hope we managed to wake you up in the morning. Maybe Mansoor, you can start with
see who is here from other European countries who are the leaders, if they can come up with and explain how the centralization of treatment is going on. Otherwise, we can start from outside Europe. Pedro, United States. Go ahead.
Yeah, first of all, congratulations and thank you for the invitation to participate in this discussion. I think it's obviously very admirable work to try to centralize and to unify and standardize regimens across the systems. I see that there's a significant focus on surgery. However, obviously, the field of gynecological oncology now is primarily not surgery. And this comes from somebody who is a surgeon in gynecological oncology. So when looking at the realms of like innovative therapies, novel therapeutics, how do you now also plan to include that component in the standardization and centralization of care for patients when in some countries that's driven by medical oncology rather than gynecological oncology? So I would be interested in your thoughts with regards to how to strategize to optimize the care for patients across all areas of gynecology.
So thank you, Pedro. I think you raised a very important point, and we are prepared for this in two ways. The first one is when we are now doing the guidelines, these guidelines will not be only on surgical quality. These guidelines will be on the management of the disease. And this is why we are working with other societies, and we are including in the panel of experts, not only gynecologists, but also medical oncologists, radiation therapists, and radiologists, for example. That's one side. So in the future, the guidelines will not be about surgical quality or surgical management, but overall management of the disease. The second one is that from the training point of view, we have expanded our training and our logbook, and we have succeeded in this because actually we received the UMS and SESMA appraisal for 2 new models in training. One is on diagnostic procedures and the other one is in systemic treatment. So right now, the new curriculum for the ESGO fellows will cover specific topics, and you may receive a special interest certificate in something which is not surgical anymore. It's diagnostic or systemic treatment. So I think we are on the right track.
And if I may to add, Denise Curlew said to me a very good sentence. We are never talking about centralization of specific surgical procedure. We are talking about centralization of management. And this is a completely different way of thinking, because some centers, they believe if they have big volume for large surgeries, that this is it. It is not. It has to be management from the diagnostic to end-of-life care, not only the surgical technique. Germany.
Pedro, you raised a very big issue because the system is against centralization. If you really focus on patient's perspective, of patient's journey, it's a defragmentation of the woman with cancer. And so in Germany, we have the law now to centralize 63 diagnoses. Ovarian cancer is one of the topic, but it's even apoplexia and many, many other diseases where you see they have many 1,000 centers. They named centers, but they are not centers inside because they look only in disciplines. And you know, we identified you need at least 144 people to deal with one woman with ovarian cancer surgery. But we are still working in centers and disciplines and defragmentating the woman. And this is what our vision is, but step by step. Let's start with woman cancer, with gynae cancer, but then find the cross, talk to the woman diseases and the woman healths, such as endometriosis, maternity, whatever. But then to look how we can save money even for the healthcare system, because defragmentation making complication, postponing best treatment, and it is huge cost intensive. And that was even the key message. But the question is how to bring it and an alliance. So what we need for women is a disease management program what focus on the patient journey from early detection, screening, up to end of life and cancer survivorship. This is a topic, and this is, I think, the power of ESGO, because we have the patient insight, we have the young generation insight, we have the researchers and we have the people who touch the patient. So what you can do with screening the patient, and you cannot make a cone biopsy. So this is a big challenge. There's no disease where we have made it. There's no Disneyland, but we can make it better what we are now. So this is our mission.
Just echoing on the same lines, I think it's really coordination and centralization. I can't really call it full centralization because it's quality control across the pathway of care. It's a QC around the pathway where you could have different models. The models need to be context specific. I don't think you can have one model that's going to fit all health systems. And you need to adapt your models following certain principles of care. But you could have a hub and spoke model, but you could have a coordinated where certain things are done central. But unless you look at the whole pathway of care, you can only achieve so much improvement in your survival outcome. And I suspect if you make small increments right across the pathway, when you put it all together, you'll probably get a much bigger bang for your buck and a much greater improvement in survival. And that sort of has worked in other contexts and health systems. And I suspect that's part of what Claus also presented. And it's not just one centralization of the operation. I mean, they have a well-coordinated pathway. They have data collections. So there's the whole systematic approach of doing it. Yeah, and in the UK, we have lots of things to do which we need to improve. But we do have this sort of a pathway, sort of hub and spoke sort of model. But we need to improve the quality across the patch, I think.
Since we are here to talk, I'm going to be provocative. Centralization in Denmark, it was a miracle in a small country that could go from 55 centers to 3 centers. In a public running system like Italy, it's more difficult. And the name of the game, unfortunately, is politics. And the politicians that they're not allowed this well-done centralization. There are a lot of resistance. So this is what we need to address to the European Parliament, to communities, in order to stress this issue, especially in public health running system countries. Because politicians, they stop this centralization. We all know the value of decentralization, and this is how the world is going. And but in some places, it's still difficult, it's still resistant.
I think that's a great remark. I would just clarify that we were struggling to centralize for many, many years. It was not possible. No surgeon will give up their bread and butter. So we had to go to the Danish parliament, convince the politicians. It came from the parliament as a law, and that made it possible. So this is exactly the same what we did. And you have to do the same. You have to go to the parliament, talk to the politicians, and make it happen from the top.
There are three more interventions, so if you want to reach the microphone, just to reply to you. Actually, in Italy, we have this law since a few days in one of the regions of Italy. So that's not true. In Lombardia now we have it, the centralization. So maybe it will happen also in other regions.
Yes, of course. That's hi everybody. My name is Paweł Nawa. I'm from Poland, and what I want to stress, what is very important, of course, that's politics and money. That's no doubt about that. But from in my country, what I see, which is, I don't want to say it's very dangerous, but it's very important because most of us, we are GYN oncologists and oncoclinicians. But from the other hand, for example, in Poland, GYN oncologist comes from OBGYNs. And what I have a problem, like a district consultant, that in my district, every gynecologist, let's say general gynecologist, could do the oncology, means surgery. But that's not a talk about surgery, that's a talk about management, absolutely. What I want to stress, that it's very, very important, maybe not to separate, because in many countries there is not only a GYN oncology position, like in Anna told me in Italy, there is OBGYN and there is a centralized centers. Of course, the discussion about if we should have or we shouldn't, that's no sense, because we have to have the centralized system in GYN oncology or women cancer health care. But the most important thing is just to talk with these groups, and the crucial role is ESGO umbrella. In many countries, what we talked today morning, that we have to, I don't want to be undiplomatic, but we have to separate general gynecologists and push and move the power into GYN oncologists, do the management of this kind of care. Because, as I said, in Poland, if you are OBGYN, you could do everything. Mm-hmm. If you are GYN oncologist, you can do everything plus chemo. That's the problem which I see in maybe not whole Europe. What the Kim stressed, thank you for your presentation, was really very sympathetic and important when you show the exactly step-by-step way. You said, I can go, I even go to United States for treatment because I'm allowed to. I'm a rich person, let's say. But 90% they are not. So your mission, my mission, our mission should be just separate general gynae and move into, then we will have a centralization. Thank you.
Yes, thank you very much. And you pointed out also the training part and certification of doctors part, which is also part of ESGO mission. If we want to have the same requirements, it goes not only to institutions, it goes also to the staff that deals with the patient.
Thank you very much. And also we are focusing also mainly in the politicians, but I think that also, at least in my country, in Spain, we have found also resistance from our colleagues from the little centers to get centralized. I remember in many places where they say, okay, I have just a couple of cases, I'm not going to send you because there are those two are my cases. And this is something that I think we can even impact more than to the politicians from ESGO and from this GYN oncology environment. So I think we shouldn't forget about our own colleagues from those centers that don't want to refer the patients. Then actually it's a lack of opportunity for the patients when they remain in these little centers without this volume and experience. So that's my comment. Thank you.
Ignacio, I love this comment because I think the most barrier are really the doctors and the disciplines, because they are not really talking about dedication and quality indicators. They talk about power. And in Germany, I can tell you the law was done by the politicians and the insurance company without any doctor. This was based on the law. And I think this is what we say, but I think...
We did it with doctors and managed it.
Yes, I just want to emphasize again the patient's voice here. Centralized care is very important. I mean, I heard a story again yesterday from one of the members from Engage. What can go wrong if there's no centralized care? And that is like in one of the Western European countries. So centralized care is very important for us for quality of care. But quality of life is also very, very important to us. And if everything is centralized in one place, again, not everyone can travel, and you need your support system. If it's just for a surgery, it's easier. If it's the whole thing, the supportive care, the maintenance care, etc., it's very important for us to have access, wherever. And I know this is a dilemma because this is complicated, but I think it's very important to emphasize that. Thank you.
Good morning, everyone. Krzysztof Rosyjski, also from Poland. I agree with my colleagues that we have to persuade our colleagues from gynecology not to operate, not to deal with the cancer. But there's also other side of that. When I started my journey with gynaecology, I was talking to patients and saying to them, okay, you have a ovarian cancer, we need time to prepare you for the operation. So we need like 2-3 weeks for rehabilitation. What I was heard, what she told me, what the patient were telling me, I need the operation right now. And she went to the other center and the operation was performed next day. We know that the result will be lower, will be poorer with such a quick operation. So my point is that we have also to persuade patients to look for the centers that deal with the cancer holistically, not to go just to the near center that she lives, because she thinks that will be the best option for her. She can go with her shoes just to the hospital next door. So that's the other thing. The doctors, we have to persuade them not to operate, not to deal with the cancer if they are not working in the center. And then the campaign for the patients. Look for the accredited centers, the quality of care and dealing with cancers, making sure that the quality of life after the treatment won't be worse than before. That is guaranteed in the centers that are accredited by ESGO or cancer unit, like we are working with Pavel to introduce the cancer center in Poland.
I'm sorry, it should be on a patient to find. I think the doctors, all the gynecologists should say this is the right place for you, that you should go. And the doctor should not be, I would say, selfish and keep the surgery. But I mean, we're very vulnerable at that time. And we might get knowledge, but maybe you don't. And not everybody is assertive. So I think you all need to take care that we get the right surgery. And it should not be on us.
A very powerful and important conclusion, which means that the development of network of centers of excellence that are based on the same criteria is crucial, because then also the patient will know, if I go to these accredited centers, everything will be managed as it should be, so they are not stressed and they know exactly what to do. But as we can see, we still have a lot of work to do in front of us. We have some very good practices from different countries, different approaches. The aim is only that at the end of the day, we have the same network and the same equal access to care and prevention in the whole Europe. Otherwise, we will face 2 Europes, 3 Europes, and problems associated with that, with migration, with everything. So this is really important, and this is really something that we jointly have to work on. Thank you very much for the first part, very interesting. And now we are going to the part 2.
Now we are going the other way around. This was something we are proud of, centralization, and how we have succeeded to it. Okay, we are 6 million, we are central, we are very organized. But we are also organized in medical oncology, but things are not moving as it should, or as I would have wished it should. And I think they're moving somewhere else. They're progressing somewhere else much better than we are doing in neighbors. And that's why I took Germany as an example. What Europe can give us, maybe we can find some ways out. So what has happened in the last decade? We have seen tremendous improvement in, I would say, survival after getting introduced new treatments to novel drugs in all 3 cancers. We have really changed the outcome of our patients. And we can be proud that Nordic society has been leading some of these trials globally. So we lead globally. We get it approved by FDA, by EMA, by Japanese society, everyone. But then we don't get it approved here. So our patients have to wait and wait and wait. And that's, I think we have to discuss how we can move ahead with that. This is statistics about approvals of novel. So in Denmark, it is when European Medicine Agency has approved a drug, the company has to submit application to the Danish Medicines Council, and they have 2 steps, and I'm sure Søren will come to that. Talking first, sorry to say, the repetition of the same, what EMA has already done to see if there is evidence enough, and then the money it cost, and is it cost effective. And I have difficulty to understand what is the cutoff one uses. I thought always the NICE, Jonathan, was the worst one in UK. But here's a comparison. The new drugs approvals compared to our neighbor countries. UK 100%, we are 63%. That is, I think we pay more taxes than you do. So I think we should have had something better here. I got help here, but what we tried to check here was when a drug, because I took Germany as an example here, when the patients could get access to a drug in Germany for the newly approved regimen. These are the regimens, just an example. And from there, how much time it took for Danish patients to get an answer. I'm saying an answer. It could be a no to receive or not receive a drug. You can see up to 41 months delay in that the decision making that German patients could get it, but our patients had to wait up to 41 months. And the last line is very important. That's the latest one. That's a drug called mirvetuximab, which after 13 months of delay got a no. But I think there is another reason there, and the reason is here. Our good friends across the pond, has put something called most favored nation. That means that in US, they have said that there are 8 countries in Europe who got a lot of rebate on in medicine, and they would make companies to get the same rebate in US as they get in, for example, in Denmark, the Danish cost. And what does that mean? Companies are not interested in submitting application to Danish Medicines Council to get it approved, because if they have to bargain the price. And the US, which is the biggest market, they have to also go down on the same price. And we are suffering because of that, right? The other thing is, our Medicine Council has this 2-step system. One is the science part, and then comes the pricing. And when you go to the pricing, and if they won't bargain, you don't get it approved. The mirvetuximab is a typical example. I don't know what happened, but I think this is a typical example that it did not approve. And I think this is just the beginning for all new drugs which are coming in, that we will not get approved in Denmark because companies will refuse to bargain the price. Because if they bargain the price for 6 million people, they have to bargain the price for 250 million people or more in US. So these are the dilemma we have, and we have to figure out what to do with that. And I tried to convince many politicians in the last 6 months to come to this session. Nobody said yes, sorry for that. But it's a great pleasure to have some other great people here who can debate it. And before that, I think it's very important to hear from our patients, because at the end it's patients who is suffering or not. So it's a great pleasure, and it's an honor that Lise Don's patient with ovarian cancer, she accepted to come and tell us about her story. Lise, please.
Thank you for inviting me to share my story. My name is Lise. I'm 59 years old. I'm a mother for 5, a grandmother, sister, wife, and a daughter. 7 years ago, in 19, I was diagnosed with the cancer. At that time, I was living in Spain with my 3 youngest kids. They were 10 and 12 years old. Obviously, the diagnosis was critical and came as a shock in many ways. We had to withdraw the kids from school overnight, leave our home and friends, and move back to Denmark. It took a while till I got the actual and final diagnosis, ovarian cancer stage 3C. It came as a shock, but in some ways also as a relief. A relief because uncertainty, wrong diagnosis, contradicting conclusions, and cancelled and unsuccessful surgeries had been the case for a while. A relief because I finally met the oncologist who took my case seriously. He looked me in my eyes and in a very respectful authority assured me and my husband that he would work with me and for me and do what was possible. He left me with the feeling that he understood the need for staying there with my children and my family, which was obviously all what mattered. He gave me the opportunity to be part of the test group for the first protocol for 3 years. After 6 cycles of chemo and surgery before and midway, I commenced the test group Niraparib and immune therapy in combination. This was my luck. Due to restrictions in Danish healthcare, Niraparib is only available to BRCA1 and 2 carriers, which I'm lucky not to be. And it was pure luck that I got active stuff after all. After 3 years, the Niraparib testing was extended, in my case, all up until 2025. Lucky me again. Being part of the first protocol test group was crucial to me. It kept my cancer staying dormant for 6 years. I'm pleased that I got the opportunity to take part of this group and thereby supporting research in new and more advanced ovarian cancer treatment, which is important as attention and funding to this type of cancer is lacking. For all mothers, daughters, sisters, and friends, I do hope that this will bring more funding to female healthcare cancer in the future. Last year, my luck was challenged and the ovarian cancer relapsed. But last week, I finalized the protocol of the relapse. So after another surgery and 6 cycles of chemo and bevacizumab alongside, I'm here sharing my story with you. I'm pleased to be here with my kids and my husband, sharing everyday life with them, bring them up, and travel the world with them. One highlight of my journey that I'd like to share with you is the difference it made to me when I met the oncologist who was not only the world champion in this medical sphere, but first and foremost, he had a very human approach to it all. He made me feel seen, heard, and treated in a way which left me with faith and trust. Obviously, I met a lot of doctors and nurses and experts, but he was my anchor point and always accessible. With an upright and honest answer, dedication, and attention. He made me understand that while he took care of the complexity of the medical treatment, research and trials, I should focus on things under my control. He also told me I could do anything to complement the medical treatment, sports foods and supplements, but asked me to bounce the supplements off with him to avoid conflicting efforts. He told me not to scrutinize the internet or other channels for research and opinions. Told me, ask me if you have any questions, anything, anytime. This trust meant everything. I have no doubt that due to this, I managed to keep away from reading and researching, and thereby from drowning in bad news, fear, and anxiety. He gave me the foundation to keep the positive and optimistic mind. It felt like a teamwork. Thank you very much.
Thanks, Lise. That was tough. Well, back to what we are struggling here. I think we will start with the example of Germany, where things happen differently. I don't know how you do that, but let's hear from Jalid how you do that before we go back to Denmark and see what we can do better.
So first of all, thank you, Mansoor and Maja. I think it's a very crucial mission that we even try to change really the care and even to bring really innovation. We talked about centralization, but you just touched, it's not only the knife, it's the moderation, but even the access to innovation. And we have 744 million women in Europe. 43 million of them are in Germany, and I have several patients from Denmark for a second opinion or to give them other access. And this is only one example. And let's think about neighborhood and to learn from each other, but even to fight for each other, because we touched financial toxicity is one of the key barriers to access to innovation. At least every third woman have a financial crisis, and they are not able to go to Berlin or to any other city. And why? And why wasting time in flying? And that's the reason I'm really proud to work with you and to fight with you even the next years. And Germany, there are very few things you can really be proud in Germany, but this is robust. This is something, because if you design the guidelines, you see the options, you see the opportunities, but what is in real world? I can tell you, as a doctor in Germany, I'm always under the law pressure, because I have to follow the law of the approval, but I have also the same way to follow the law for the patients to offer her the best treatment independent from my region. It's a German law in the conflict. And this is a missing opportunity if we don't give the woman the access. And you know the process, US is still the largest market, but the second biggest market and the field is at the moment still Europe. And how we can go to innovation for our patients. And in Germany, you know, we have a reliable process. And even me as a doctor in the Cancer Society, we even reflect after the approval the risk-benefit relationship, what is the backbone for the pricing. We can support and we can tell them that survival is key element, but even progression-free survival for brain cancer, for instance, is beneficial for the patient. So we are working in alliance with the advocacy, with the doctors, even to give reflection to our GBA, what is the structure after we got the approval. in general, between 60 to 100 days, the new treatment is available in Germany. And that's not always postponed from the administration. Sometimes it's even by the health, by the stakeholders, by the industry, because they are not providing so fast the drug. So it's really amazing that they structured several years ago, and it's still reliable. And this is, I think, even important for the companies, because to prepare, to educate, to train with us as a societies, our doctors, our nurses, our patients, to inform them needs a little bit time, yes. So, and I can show you in this reimbursement model that in comparison to many other countries, it's a very reliable process. And, you know, in Greece, for instance, who is from Greece? I am here. They require that there are already 5 approvals in Europe available, then they go into the field. And that's a similar situation sometimes. And that's the reason I think it's really important that we harmonize, but even we fight for each other. And I did my best only to give a feeling what happened with a woman if we postpone treatments, what induce over a survival. You cannot re-challenge them. You're missing opportunities for the patients. And this is, I think, the message what we have to bring to the politicians and to the society, that besides the opportunities of clinical trials, this should be the backbone. If we do the trials in Gaard and GOG, we want to bring it to the patients. And this is something what I only want to show you. They try even from the European level to harmonize this in a level. It's still in the process, yes, but it's still gapping. And what I only want to show you, after 1 year, if the drug is approved, then the official review from the authorities start in Germany. I think similar what UK is doing, to look how is the benefit in comparison to the standard of care before, to use this as a backbone for the pricing. And more than 90% of all drugs survived, even if there are other opportunities. So all PARPs are available in Germany. All checkpoints are available. And then we can use our patient's perspective. We can use our biomarker models then to try to tailor what treatment for what. And this is something not only for the gynae diseases, is for all cancer drugs. I'm really proud of this. And this, I think, creating even trust to the innovative structures and to our researchers. And this is something what I think is maybe a good example. And this is something what I want to bring all over Europe. And this is my personal mission, following honor, access, and to break the inequity in cancer care. So thank you very much for having my input. Thank you.
I think this is a difficult topic. We have, I would say, a role model here, Germany. They have a different system. We have a different system, but probably something can be done. I think we are trying to do something as good as possible, but we are not there. And as you saw the statistics, we are not there. So it would be nice to hear 2 most important persons who are in the room here to talk about it. The first one is director himself of Danish Medicines Council, which was quite, I would say, Sean, I was always very frustrated with Danish Medicines Council and their decisions. So please come and tell us your work. And I respect your work, but yeah, you know my
view. Thank you very much, and thank you very much for the invitation to speak here today and talk about the work in the Danish Medicines Council. I will try to convince you that we are maybe better than our rumor, but let's see. I will say a little bit about some of the challenges that we see and some of our proposals for some of the solutions. But before going to that, I will talk a little bit about the Danish Medicines Council and how we work. So to begin, just let me see, I should click here. The mission for the Danish Medicines Council is to strive to ensure timely patient access to clinically effective and cost-efficient treatments. This is what we are working for every day in the council and in the secretariat. So we work from, our work is governed by 7 principles that are given by the Danish Parliament, and 2 principles are given from what is called Danish regions. That is a collaboration between the regions in Denmark, and it's the Danish regions who has formally given the Danish Medicine Councils our mandate. The principle stipulates that we should work with high scientific standards and balance rapid uptake with cost effectiveness, as you already mentioned, Mansoor. We must make sure that our decisions are transparent to the general public and independent of political decisions. We are also guided by a severity principle and what is called a cautionous principles. I will not come much into that today in my talk, but of course I can allude on that. So standing on the principles given to us by the Danish Parliament, the Medicines Council must balance the added benefit to the added costs of new treatments, as is done in many other countries. This is evaluated in the light of the uncertainties stemming from the clinical trials, and we also evaluate security issues as they're part of the quality of life for patients. And we look at patient preferences and also look at the resources that are devoted to each treatment in the healthcare sector. I will address this balancing in a short while, but before coming to that, I will just say that the Danish Medicines Council published a strategy last year, and we set 3 priorities that we will focus on in the coming years. So the Danish Medicines Council must deliver effective drug assessments for the benefit of patients. I'll come back to that, what we mean by effective assessments. We should be leading in prioritization, and we should be a collaborative and visible actor in the Danish healthcare sector. So these 3 focus areas were chosen on the background of what we see as 6 trends in pharmaceuticals. They are not new trends, but they are trends that has been working for many years, and I think will be working in the coming years as well. And one is that we see a high demand in the public for healthcare services. That's a good thing, but it also increases the cost for new treatments, and therefore it's a trend and a challenge at the same time. We see growing uncertainty related to the effectiveness of new treatments. I will come back to that. We see more development of treatments for small patient groups and personalized medicines. We see increasing requirements for sustainability in the healthcare sector, and by that I mean both economically but also with respect to climate change. We see a need for coherence across primary and secondary care, and we see a greater European cooperation in this field. So today I will focus mostly on uncertainty about effectiveness of new treatments and our suggestions for solution in this space. So the growing uncertainty about new treatments is shown by the fact that 20% of FDA accelerated approvals of cancer treatments from 1992 to 2023 were actually withdrawn, especially in the last 3 years of the period of this study has looked at. And in 23, looking at Europe, more than half of cancer treatments approved by EMA was actually given a conditional approval. So back to the balancing. So these challenges poses a challenge for patient access to new treatments. The increased uncertainty in added effects and pricing increases the uncertainty of the benefit for the healthcare, but also for patients. Despite of this development, as I mentioned in the beginning, we in the Danish Medicine Council strive to ensure patient access to clinically effective and cost-efficient treatments. Therefore, we are very keen to find solutions that can overcome this increased uncertainty in many new treatments. And we see here that risk sharing between the pharmaceutical industry and the healthcare sector as a main way forward, and also the use of real-world data post-marketing as an important way forward to increase the benefits for patients and for healthcare. It was already mentioned that the Danish government years back has made a number of cancer plans, cancer packages, as it's called in Danish. And last year, the government published its 5th cancer plan. One of the initiatives there was that the Danish Medicines Council was giving funding for a national partnership on real-world evidence pilot projects, as we call it. The initiative should strengthen the possibilities for the Danish Medicines Council to issue conditional recommendations for new cancer medicines to a great extent, allowing patients to gain rapid access to potentially better treatments. So our ambition is to use real-world evidence to support better risk sharing between industry and healthcare, thereby overcoming the increased uncertainty and improve patient access. I will also give a few remarks on the access in Denmark. So we have looked at Scandinavia, Norway, Sweden, and Denmark. And in Scandinavia, there has been 3 assessments in cancer. This is cancer broadly, that have been assessed in all 3 countries and where they have made a conclusion. As you can see, that 63% was approved in Denmark and 68% in Norway, whereas Sweden has a little bit higher approval rate. When we look at it, there are 8 that are recommended in Denmark that are not recommended in Denmark, but are recommended in either Norway or Sweden. When we looked at it, 3 was without documented effect on overall survival, and in 5 other cases, there were equitable and more affordable treatments available for patients. We also looked at ATMPs, advanced treatments, and in Denmark, we have approved 13 ATMP to 13 indications and 12 in Sweden, 9 in Norway. So if I look across these figures, I don't see, I see little marked systematic differences between the Scandinavian countries in approval rates. And then looking specifically on Denmark, we have seen a stark increase in the number of applications from companies. So we reached a record of 84 applications from companies last year. That could be new treatments, it could be also new indications, and it could also be re-application if there has been a non-decision previously. But it was a record high, and this year we have already 75 applications from companies that we must look at this year, and we are only in the beginning of the year. So I see this as a very strong interest in companies in applying and putting patient access to Denmark. I haven't prepared any suggestions on the most favored nation. Maybe you can have that in the talk. But I see this, at least for now, there's still good interest in applying for Denmark. The timeline from EMA has given a positive opinion is, of course, in Denmark, our responsibility that we are fast in assessing applications, but it's also a responsibility for companies to apply to Denmark quickly after a positive opinion. And we can see that there has been a little increase in the median time for the time that companies use from positive opinion in EMA to actually applying into the Danish Medicines Council. Our timeline is in median terms unchanged the last few years. Because of many cases, we actually see an increase in our processing time, and we are working hard on bringing that down again. Another important point here is that the time from the Danish Medicines Council has made an approval decision, it takes from 1 day to 14 days before the treatment actually is in the clinic, in the hospital, and patient can have access to that treatment. I think that is very fast looking at other countries, and that is because we have a very great cooperation with the buyer, Amcos, the organization buying the medicine that delivers it to hospitals right away after a decision. And we also have universal and free access in Denmark. So I think these 2 points is part of the overall picture of availability for patients in Denmark. As a final point, it was already alluded to, we are actively engaging in the EU health technology assessments in the pharma field. We are part of the assessment teams, and we also have a strong Nordic cooperation where we offer companies the possibility of a common Nordic evaluation of applications, and this makes it possible for a uniform assessment both on the health effect and also on the economic health economic effects. Unfortunately, we experience only low interest from companies in actually doing the Nordic common assessments, but we really want to do more of that in order to save resources, but also have more uniform assessments across the Scandinavian countries. So conclude, I think the increase in uncertainty in added benefits of new treatments demands more sharing, demands more use of real-world evidence, and we will very much like to cooperate with companies, with clinicians in finding models that we can use this more. I think Denmark is implementing fast. When we look at the FPR data, we are one of the fastest in Denmark. And I think international cooperation is increasingly important so we can have more uniform and faster assessments in Denmark and in Europe. Thank you very much for your attention.
Even better, I would say. Now I would like to invite Thomas Senderovitz, Senderovitz, almost there. He has a great CV. You have been director of the Ministry of Lægemiddelstyrelsen, I would say Ministry of Health. In that case, it's united. And then you moved to this position as president of the Danish Association for the Pharmaceutical Industry. So you have actually both sides of the coin in your experience, and it would be great to hear your thoughts, how we can do better.
Thanks a lot, Mansoor, and thank you for the invitation to talk here. It's a very timely topic you bring up, Mansoor. We are here at the beginning of the Congress and in oncology, but this goes far beyond oncology. I just want to put that on the table. Before I dive in on the slides, just a few added comments to my background. I'm not practicing, thank God, anymore because it's too long, but I'm a physician, so it's the work with patients is very close to my heart. But since I stopped practicing medicine for many, many years ago, I went in, have been in pharmaceutical R&D across the world, then went into the Danish Medicines Agency. I wasn't heading the ministry. I wish I were, but I was a regulator, and I was chairing the European Heads of Medicines Agencies network, and I was at the board of the European Medicines Agency, and I was there smack in the middle of the Corona crisis. And I'm mentioning this not to brag, but actually to say, during the Corona crisis, we saw how the public system, healthcare system, and the pharmaceutical industry worked very closely, and we were actually able to bring vaccines in world record time out to the European citizens. So it's possible to bring innovation out fast, and I'd like us to not forget what happened during Corona. So that was just sort of the fly-in, but this is actually I want to also reflect on today's meeting, and I was really seriously touched by the two patient stories, because that's what it's all about. At the end of the day, This is about creating a healthier Denmark, a healthier Europe. Actually, when you work with global companies in global healthcare, you want to have the same globally. But let's solve what we can do for Europe here. To have a healthcare system where the dreams and the visions, which I really admire, of more centralized or more collaborative, whether that's in oncology or whether that's in other disease areas. This is possible when you really have the total ecosystem working in sync. The ecosystem of educating experts, well-functioning infrastructures, well-functioning healthcare systems, hospitals, primary care, speedy access to innovative treatments, whether that's innovative surgery or innovative medicines, and not forgetting that you need money to do that. And I just representing the industry want to make everyone aware that the life science industry in Europe and in Denmark in particular is one of the key drivers of income to the European money box. So without top line, there will be no innovation and there will be not enough money for that. Let's take a little look, and I'm stepping a little bit outside here of my manuscript, but I'll come back to it rapidly. I'm a speed talker. But we have lost the big tech game to China and US, and that's a huge thing now. Car industry, we have pretty much lost to China. Are we going to lose our life science and our healthcare and be copycats and be depending on what happens elsewhere? As a European citizen, I would not like that to happen. This requires continued, and I'm just talking about life science, you can take the same in other tech areas or other industries. We are now in a geopolitical situation where we're being focused on not losing that game, but being equally competitive to US and China is a foundation for being able to afford what you have been talking about this morning and what the rest of the conference is most certainly also about. And now back to the manuscript. So, the need, as you can see here, we've heard it today. We've heard two patients talk about this. We've heard you talk about this. We need fast and undelayed access to innovative treatments, and I fully understand they need to work. They're actually already evaluated by the regulatory authorities, so let's not reevaluate that. And then, of course, it's totally reasonable that they have to somehow make value for money. The question is, which money and which costs? And we have had a tendency in Denmark and other countries to look entirely in one money box, the healthcare system. We have not been good enough in looking at add-on dynamic effects. If you can prevent subsequent healthcare needs or nursery homes or other costs, if you are homesick and cannot be productive, those costs have not been part of this. And that's a mistake, because looking in small money boxes in a societal economic situation where you really have to benefit for the total society is not rational. And I'm not blaming anyone for it, because that has been the mandate. Sorry for that, excuse me. That has been the mandate, but we have to look at that. So that's already one of the potential solutions, so that we change the frameworks and mandates for whichever HTA body looking. So it's not just, are we saving money here in the hospitals? But if we are spending more money in the communes or in the regions or in the home care, we haven't gained any money or done anything good for the Danish or European society at large. Equal access to medicines, equal access, you heard that, also across genders. And I have to be, being a male, saying in the last several hundred years, it hasn't been women's health that has been equally in focus. So increasing the focus and making equal access across genders, geography, socioeconomic factors, and then ensure innovation continues. How is innovation made? It's very rarely made with leapfrogs. It's made with steps by steps. So there's about risk willingness also by the HTA bodies, not to be overly, I saw the demand from the regions to be precautious. I dare that precaution is always the right. I'm not saying being blind and just jump out of the cliff, but if you want to make innovation sustainable, you've got to have some risk willingness. And I can tell you, when you are a patient suffering from cancer, and all of us either have had it or have relatives, your risk willingness go up because the alternative is worse. So as a society, if you want to have an ongoing innovation, you need to be more risk willing, not blindly so, but you can be too conservative. And I think that's a balance that needs to be looked at. Are we at the right balance? The challenges. We haven't been given enough focus to R&D across industry as well, public research and so forth in women's health. We have increasing national barriers and burdens. And Europe is not an open inner market. We've just seen it. We're a mosaic, we're a patchwork. And I'm not very good at patchwork when it comes to the hobby of patchwork. That might be good. But when you're looking at speedy access and harmonized access across, then having a market or a region which is so patchwork doesn't help. The national barriers across EU makes EU, all other things considered, a less interesting market. And I know that we are still the second largest, but look at the Draghi report from 24. Europe has been sleeping. We have been saying, oh, we're doing great. We don't have to have a defense, and we are world champions in tech. No, we are not. We're world champions in pharmaceuticals. Well, China is increasing rapidly in innovation. And I can tell you, if you compare with US and EMA, there are more applications sent to FDA, just the applications, than there is to EMA, and that gap is increasing. And then if you add up the access barriers across Europe, we're not picking on Denmark, but we're here in Denmark, so we take Denmark as an example, but it's the same in many other countries, and other countries it's worse. Then the patients at the end of the day are being filtered disadvantagedly in Europe versus US. And in the future, we will see China and subsequently India taking over. And then we can sit and say, oh, we are looking at the costs here in Denmark, but we're losing the bigger game. And I'm really concerned as a citizen about that. And then, now we talked about the most favored nation. And if people haven't understood it, and I look at the figures, Søren, I fully accept it looks promising right now, but it's not going to stay like that. The most favored nation reference price system, which I will show a little bit about in a second, is just adding to it here. I don't want to step on this and continue. You already showed the figures, Mansoor, and you know, we have, you can see the red circle is Denmark now. A few years ago, we were in top 3. Now we're sliding down the accessibility and the time it takes for patients to get access, or even the number of recommendations being done. And I'm not blaming the council at all. I don't want to do that. These are the framework, but maybe there's an inbuilt conservatism because of the mandate and how we're looking at it. And that's part of the solution. I was asked to come with solutions, and I'll come with that in a second. So this already started under the Biden administration. So let's not say, oh, it's Trump and it will go away. Under the Biden administration, a concept called IRA, and you may know that from US, the Inflation Reduction Act, was the beginning. And this is a reference price system. But let's be clear, we have had reference price systems in Europe for quite some time, trying to negotiate the prices down. So maybe there is a certain sense of, should US market pay everything? And I know the US pricing system and market system is rather complex, and some would say maybe not the most logical, but alas, it's there. And I can't change that. But what we can change is how we do it in Europe. And Denmark, for whatever reason, ended up in the comparison box with the G7 countries plus Switzerland and Denmark. Which means for a market in Denmark, and I'm giving this as a proxy, and then you can go home and think of your own countries, we are only 0.3% of the global market. So any big company who has a business to run, and the profits and earning of those businesses are the foundations of all of our pension schemes as well. So let's think about the totality of the ecosystem here. The risk of launching, the uncertainty and risk in and of itself of launching a new medicine in a country, if the price and the accessibility is so risky, they would rather not do it, because it can drive the whole, more than 50% of their business, which is the US market, is 52% of the global pharma market. These are just the dynamics we have in the world. So we are fully in control, 100% in control in Denmark and in Europe to change this. We do not have to wait for anyone else. This is urgent. We are already seeing now companies not submitting to the National Council, the Danish Medicines Council, or withdrawing from the market. And the losers in the first row are the patients. But not just the patients, because then the clinical research, you will not do clinical trials in the country if you're not launching there. The interest in investing in clinical trials will go down. If this happens across Europe, we're all in a bad place, because clinical research, all other things being equal, increases the science. Oh, I've had it with you. Increases the science, sorry for that, increases the science, increases the quality of the treatment. And the next thing that will happen is, why do we have to have production facilities? Now we're talking about the foundation, and it will not happen tomorrow, but this is a potential negative spiral that I'm also concerned about. But here today we're talking about the patients and the access to the medicines. So now the last point here is the solutions. Let me just say what I'm really pleased about is in Denmark we have now had very good discussions and dialogue with the ministries of health and commerce, with the regions where Søren council is there. So we are not in the criticizing mode. These are observations and fears. We're in the solution mode, and we have now potential solutions. What I'm showing here are ideas, but the real solutions will be done in collaborations with the stakeholders. And here, Denmark can do something that I hope other countries will learn from. We sit together with the stakeholders, industry, regulators, payers, politicians, and we put potential solutions. I am not, of course, the one who will then decide on the solutions. That's the politicians. But we can help co-engineer and co-create these solutions. So an example, general example, we need to make sure that we invest. We is not just public funding, but it's also, we need to invest in frameworks, all the way from education and research to being willing to pay for innovative medicines. Because doing that creates a better overall ecosystem and economy. We have to make the EU a leading life science, healthcare, research continent again. We are losing that battle. We need to get back on track. If we believe that the Western European democratic system we live in is the least evil of all evils, or the best, depending on where you see it, we need to fight for it. We need to increase the willingness to invest in novel medicines. More flexible frameworks with incentives leading to more recommendations. Faster access. You could think about the day after EMA has approved, or the Commission has approved it. It's the Commission that approves, not EMA. They give a recommendation. The medicine is accessible at a negotiated price with the buyer, and then the HTA assessment starts, and then after 6 or 8 months, it doesn't show, then you can always talk about what are the paybacks, etc. But then you are not delaying access to patients. So that's a solution one could think about. And I'm giving this more use of real-world evidence. Look at EMA, strengthen EMA more so that the EMA regulatory process in and of itself could be faster, and then shorten the gap between EMA and HTA. So these are some of the potential solutions. Now we have to go into the machine room and solve, and we are working closely with other countries so that this is not just done in Denmark in isolation. We have to think across all of Europe. It's unheard of that we have this delay in access to those patients like we heard of today, because it costs human lives, it costs productivity, it costs quality of life. Thank you.
We have a solution. I think, Søren, you were on it. Why don't you, if this is, I love the last solution very much, and I will question you, Søren. When the pharma comes in with a new drug, apply, why don't you right away start the real-world evidence trial? You gather the evidence, you let it be accessed to the patients from the beginning while you are working on it, and you would have the results in 10 months or 41 months as some of the drugs, but you would not, the patient will not suffer. Could you comment on that?
First of all, the Danish model is different. So the Danish model is that there should be applications, so that's sort of our framework conditions, and I guess that's a political question whether you want to change that or not. I think we want to use more real-world evidence. I think we should do that in cooperation with companies, in cooperation with clinicians. There are several issues that we should discuss more, and that's why we have made this national partnership where our industry is part of, patient organizations are part of, clinicians, the national authorities are part of it. So we have to work on that, and what the solution ends up with, I think we have to see, but I fully agree we should go there. You mentioned also, Thomas, more managed entry managed agreements, and we are also very open for that. It sometimes comes down to the specificities, but we have to work on that. We have to be aware of that if you put things on the market and to patients, and if we evaluate it's not reasonable added value compared to the cost, then we have to withdraw it again. And I think that's a difficult issue to withdraw something that's already available for patients if you don't think as a health care sector you can afford it given the prices given by companies. So I think you have to think carefully before going in that direction. I know it's working the other way around in Germany. I don't know if there's issues there as well. And then I think again in Denmark we have access when it's approved in the Danish Medicines Council. It's accessible everywhere in the Danish healthcare system. I would say that in some, at least, insurance-based system, I don't think that's the same. So I think that we also have some very important positive thing in the Danish system that we should look to. And I think it was mentioned that Denmark is a small country. Yes, that's why some things are easier in Denmark. I think that's true. I think also what we are good at in Denmark is cooperation between industry, between the healthcare sector, between the government, and I think we should keep on to that. That's very pivotal part of the Danish model. And I think we have a task force now on most favored nation, where Thomas is part of, and the government and Danish region.
Which is a great achievement that we have a task force which is working, and I really appreciate that. I think what I feel, being in the field, that we are by getting the Danish Medicines Council started, we are at the era where UK was when the NICE was introduced, but they found a model with Crook. And I would like to ask Jonathan, with the Cancer Research UK and the combination with NICE, you get the drugs quite fast to the patients.
Not always, not always. I was a little surprised to see your figure of 100%. I'm not sure whether that's entirely correct. It is a struggle. There are many sort of health economic reasons, principally, why it is difficult to bring all these drugs in. I think, for some of them we have been fortunate, but others it's more of a struggle. And I think it's going to get harder. I think particularly in Gynaecology, where we're seeing a lot of new drugs coming through for small groups of patients, so biomarker-driven therapies.
Antibody-drug conjugates.
And cost. It's going to be a real challenge. So, I think it's just one model. It was one of the first to start. It was one that had a lot of criticisms when it first started because it sort of stood out. But other countries are following similar lines, and people are experiencing similar problems as we're experiencing too.
Thomas, are we going to improve, or is there a hope?
I'll give you the answer when we work with the task force. I think there will be improvements because there are opportunities to adjust. But my point is, it's not just about Søren's team sitting with a certain set of a framework and a mandate. You need to have a political mandate that changes. You need to do it not just in Denmark. If we fix it perfectly in Denmark and it's not fixed in UK and France and Spain and Italy and other countries, then we have gone nowhere. So we need to start fixing it in some countries and then make sure that we can reduce the patchwork effect in Europe. And then we need to make some decisions. Are we willing to pay more for innovation if it makes sense in a bigger economic framework than just the healthcare system? And that's the question. Without a lot of analytics, we started to increase our defense costs because we saw the threat here. I think there is a threat to Europe if we can't finance Europe's future and we do not have healthy enough populations. But that doesn't mean, of course, that everything should just be giving, the top price. There must be a balancing. We're not arguing against an HTA process at all. No one is arguing against that. But it may be changing the European pendulum back to being in the leading seat.
I think this discussion shows how relevant it is that we talk to each other, because even the fact that most of the drugs are really approved show that even the studies are not bad. And we are working with the companies to design trials with a better outcome parameters. And it will be becoming more and more, I think, robust. So if 90% are really approved, it's a discussion of pricing. That's a different topic. But I think what we learned in Germany, to give access and then to start immediately the evaluation and to discuss how much, what is a comparator, what is the endpoint value, and this is helpful. But at the end of the day, if 90% is good, so we are not afraid that the 10% where we believe it's not good enough to stop, because most patients will benefit from this. And the other hand, we need the healthcare system, because if we give innovation, we can stop non-effective treatments, what we already paying every day. And I think this is a balance.
Really, really great conversation and discussion. And actually, thank you for setting up the session. It's a really complicated issue, as we can see. I really like the fact that you're looking at solutions. I think the structure you're trying to develop, where you have industry in the room and you're having that conversation to see where you can draw the boundaries and margins and have those negotiations to set a threshold for affordability. If you look at cancer care and health system and cost by proportion of GDP, they're going like this. We're on a non-sustainable trajectory. The country which is the worst off, I think, is the US health system, because they are that way. Europe's still quite reasonably maintained. But we can't, it requires a broader societal conversation. We can have the solutions, like you said, moving from a healthcare payer perspective to a societal perspective, and there are some health systems and institutions and policy and decision makers which take the societal perspective, and there's some which don't. You can also change your threshold. One of the things I'd put to decision makers and policy makers is that when you set your threshold, how many years ago was it? And what is the value of your currency today compared to when you set your threshold? So that's another argument you could use to increase it. It's not inflation indexed, it's not currency value indexed, and it's not in any health system. So I'm not critical of any health system. It's a criticism I have of all health systems. So what you could buy 20 years ago in the UK, when I set the threshold at 20,000 to 30,000 pounds per quality, our threshold is just going up. In April, there'll be an announcement it's going from 25 to 35,000 pounds per quality. So UK is going to raise its cost effectiveness threshold. But the value of the pound, when you set the threshold compared to 2, if I do a calculation today, it's about 40,000 or 40,000 plus. So actually, in real terms, you're depreciating what you can buy with the same amount of money today compared to what it was. So from a budget point of view, from a financial health system point of view, they probably like it. But actually, from a patient, utility, and societal perspective, it's not indexed. So you're losing money in a sense for what you can buy. So those are potential solutions. So moving to societal perspectives, indexing it. But at the end of the day, the money has to come from some finite pot. And it's a big societal question. So we can't do this in isolation. And I don't think we should be negotiating with companies personally once the drug comes in. Because there is one of the reasons for financial toxicities in the health system is the drivers for commercial companies are indexed on stock exchanges. I'm not against, we all work with pharma companies, and so this is not a complete criticism of the system as such, but they have drivers which are not aligned with healthcare provider drivers or people who are delivering healthcare or those who are budgeting for healthcare, because they are indexed to the stock price. The CEO of a company, his remit is to maximize his share price. So there is actually, his incentive is he might not be there for 5 years, after 5 years, or 3 years, or 4 years. So he's not incentivized into long-term thinking. No commercial company, most commercial companies are not incentivized into long-term thinking. And that is also part of the reason of toxicity in the healthcare system. They want to maximize, they want to sell the drugs. They're not going to necessarily do a trial on a drug that might be as efficacious and going to cost more. It's going to cost less. They are going to incentivize, they are incentivized to market, do trials and drugs which are going to cost more, earn more revenue, and therefore be better in the stock market for them. That's okay, that's the system, and we have a market economy. Well, it requires I just want to make the point, it requires a much broader conversation, which needs to involve industry, needs to involve society. At the end of the day, taxpayers paying for it. So, yeah.
Thank you very much. First of all, thank you for this excellent pre-meeting, I guess, and the topic. And I'm representing AstraZeneca, heading up AstraZeneca in Denmark. And I'm not going to add a lot to what Thomas said because he was very precise representing the industry. But what I do want to say, maybe offering a slightly different view, is, coming from AstraZeneca, Europe is important. We're European-based, right? But not, recently we have announced an investment of 50 billion in US by 2030. And we did similar for China, 15 billion by 2030 as well. I haven't heard that announcement for Europe. And it's coming back to the fact that, yes, there may not be full alignment with the objectives, but there is an element about me being responsible for Denmark, where we have 80 clinical trials approximately running right now out of 400. So Denmark is the country with most clinical trials per inhabitant. And we're actually also the company with currently most submissions to the Medicines Council. And we are getting rejections. And we're getting rejections not only on Lynparza that you saw with 41 months delay, and HER2 is another one for breast cancer, where we knew patients had to go to Germany, by the way, to get the treatment. And you guys, I know you have a very clear mandate, so I don't want to, Medicines Council has its mandate. But I'm asking also Søren, but all of you, to speak up on behalf of the patients, because I know that's what the politicians are going to listen to as well. If you guys want to maintain the level of investment, the clinical trials, there's nothing more I want to do. In fact, I've also said to Søren, we're going to submit everyone. We're not going to pull submissions. I want the patients to have access. I've said that. But let's make sure that the uncertainties, because we're going to move into areas, PFS, whatever endpoints that is not all-cause mortality. It's going to be more and more. In particular, we're moving into the field of new adjuvant, where currently you're not approving anything, I'm sorry to say. This is not supporting innovation in any sense. This uncertainty, if you don't do that, we're in problems. So I just wanted to have that view coming across as well.
I just want to say, I agree with the previous speaker that it's a very broad discussion. You said it as well, Thomas. So it's what are the public health budget, innovation, and so on, and therefore it's very fruitful to have a discussion, and it's very, I think, healthy for our society to have these discussions. In Denmark, it's just to make sure that we actually do approve very expensive treatments. I think the one that I recall that was the most expensive in list prices, it was 3 million euros. I cannot say what we paid for it, but in list prices it was very expensive because it had very good effects on quality of life. So it's still, I think we should also, as a healthcare sector, evaluate what are the added benefits in quality of life and have a negotiation of the price. I think we should also be a buyer in this sense, and that's one of our jobs, is to actually supply the buyer with information on how to go into a negotiation with prices. But we have no ambition of standing in the way of innovation or clinical trials, but we have to do our job, and we also want to evaluate or develop the way that we work in HTA evaluation. We are looking very much to the NICE because they are the front runner in HTA modeling and methods. So we look very much to that and try to be very efficient. And as I said, we would very much like to be leading in prioritization, in the sense that we should use the best method. We should be the ones that are finding solutions in managed entry agreements and so on and so forth. Thank you.
This is a great concluding remark. Thank you very much. And we started this legacy group, and thank you to our collaborators for that. And we, Maja, if you can also come here and conclude, we are not letting you be off hook. We will come back in 6 months and in 1 year, and we will try to reassess where we are, both with the centralization to the rest of the Europe and for this subject here in now. And thank you so much. I think we have succeeded with this new experiment of legacy event.
Yes.
Did we?
Yes, we did. I'm really happy how it turned out. As this is the first one. We just broke the ice, right? And I think as a conclusion remark, what we can see is that in Europe, the biggest problem is fragmentation.
Yeah.
Fragmentation on all levels, inside the countries, between professionals and policymakers, and in the whole Euro perspective. And this is actually the biggest problem that makes disparities and inequalities and makes people angry. And then the politicians that appear based on this anger are also not constructive. And this is, I think, the most important problem in Europe.
Yeah.
And I really hope that ESGO and local politicians and policymakers will find a way to work toward diminishing these fragmentations. We really need to have one voice in Europe.